Thank you, Dr. Hollier, and good morning. It is my honor and privilege, was making sure that I wasn't getting ahead of myself. I saw my slides hop up for later. It is my honor and privilege to introduce our keynote speaker this morning. So as we work on getting Dr. Hollier's slides up, I am going to continue with our introduction here. So as I said, it's my honor and privilege to be here this morning to introduce Dr. Lisa Hollier. Dr. Hollier is the president of the American College of Obstetricians and Gynecologists. She is also currently serving as ACOG's interim executive vice president and CEO. She is a professor of obstetrics and gynecology at Baylor Health at Texas Children's Health Plan. She completed a residency in OBGYN and a fellowship in maternal fetal medicine. Her strategic initiatives at ACOG focus on reducing preventable maternal mortality. Throughout her career, she has been dedicated to caring for the underserved and improving women's health by advancing women's health policy. Please help me in welcoming Dr. Hollier to the stage.
Thank you so much. It is such an incredible pleasure for me to be here today. I am really excited to have this opportunity to talk with all of you about improving the health of women and children. This has been my passion throughout my entire career, and so to have this chance to stand in front of so many people that I absolutely love dearly is incredible. As we go through the information today, what I would really like to do is sort of take you on a journey. The first thing that I have to do is to thank the Department of State Health Services, Maternal Child Health Epidemiology. Allison, thank you for all of the work that you do. You're doing just an incredible job, and the entire team in Maternal Child Health Epidemiology. Also to Dr. Hall and her entire team. Thank you, Jeremy, for all of the work that you do. And everyone in Community Health Improvement has done such a terrific job bringing together the work of the Maternal Mortality and Morbidity Task Force. So yes, thank you very much. The members of the task force do completely volunteer their time. Many of you are sitting in the audience today. Thank you, Pat. Thank you, Amy. It is an incredible opportunity to work with such amazing people. Thank you, June. And really big thanks to you, Carla, so much for being my partner in this crazy adventure that we have had. You're absolutely terrific, and I love having the opportunity to work with you. Over the last couple of weeks, I've had the chance to attend a number of different meetings. And these are the things that I've heard about implementation. It's hard, right? This is the really hard work. But this is the work that matters. Because it doesn't matter how amazing our clinical guidance is if it just sits there as a document out there on the web. It doesn't matter how cool our toolkit is or how amazing our bundle is if it isn't used. If someone just like you, every single day, doesn't use that information to truly make a difference. None of the things that we develop make any difference if we don't use them. If we are not out there every single day implementing, no matter how hard it is, annoying it is, or complicated it is, we need to be implementing the incredible solutions that we're developing. Why? This is why. Many of you know why I do what I do. When I was a young resident, a young woman came into labor and delivery, and she had the worst headache of her life. Within minutes, she lost consciousness. Her baby's heart rate decelerated dramatically. She was taken to the operating room and had a cesarean delivery and delivered a healthy baby girl. Unfortunately, my patient never woke up. She spent the day in the intensive care unit. We were trying everything we could, but unfortunately, she'd had a massive intracranial hemorrhage and did not survive. Those moments stay with you. They stay with you forever, and that is why we are here. That is why it's so incredibly important for us to implement the changes that we are talking about. So as we go on this journey today, as we talk about the data, I want you to think about the women, think about the families whose lives we are changing by the amazing work that each one of us can do. Each one of us can do this every day, make our little changes that make a huge difference. When we first started on this journey a number of years ago, and we were looking at our data, our maternal mortality rate was rising dramatically. And in fact, in 2016, there was a report in Obstetrics and Gynecology, we call it the Green Journal, that said Texas is the worst. Our state had a doubling in the maternal mortality rate between 2011 and 2012. And because of that incredible increase in the maternal mortality rate, we couldn't be combined with the rest of the nation's data. What we did when we were going through all of the detailed records, we were able to find that unfortunately, there were some errors in the death certificates, and using the information from the death certificates alone, using solely vital statistics information, there was both underreporting and overreporting of maternal mortality. Unfortunately, there was a lot more overreporting than underreporting, and Texas actually had only about half the number of deaths. Using this information, the Department of State Health Services has transitioned to a different case identification system so that we can find the women who lost their lives, who suffered maternal mortality, and we can do the detailed case reviews for those women and identify the causes and the contributing factors for the purpose of developing solutions for us to implement and change the outcomes. This was a very, very important first step. And it's led us to the place where we are with our 2018 Maternal Mortality and Morbidity Task Force report. This is issued every 2 years as mandated by the legislation that formed the task force. Many of you will notice, though, if you go out to the web to our task force site, you'll see a number of different publications that provide you with a lot more data, a lot more depth on the data, and a lot more history of where our publications came from. So I really want to call your attention to the report and all the information that's in it. On the journey that we're going to take today, I want you to be thinking about the women that we talk about, the cases that we talk about, and what you can do to change the outcomes. We have heard so many amazing solutions. Just yesterday, we heard a plethora of solutions that, if implemented, would change these outcomes. So I want you to be thinking about that. Let's start here. In 2012, the task force identified 89 deaths, 89 women who died within the first year after the end of a pregnancy. There were 34 cases that were categorized by the task force as pregnancy-related, meaning if the woman had not been pregnant, she would not have died. It's a very simple way of looking at that question. 50 cases were categorized as pregnancy-associated but not related, which means they occurred within that time period, within a year of the end of a pregnancy or during pregnancy itself, but they were not specifically related to the pregnancy. And then in 5 cases, we just couldn't quite be sure, again, if a woman had been pregnant, would she have died? So let's take all of those pregnancy-related deaths. As we look at that specific cohort of deaths, what we identified were these top causes. Cardiovascular and coronary conditions top the list. This is not unexpected. When we look at national data, for example, from the CDC's pregnancy mortality surveillance system, what they've identified is that the combination of cardiovascular events and cardiomyopathy account for approximately 1 in 4 maternal deaths. So it's not surprising to us that we identified cardiovascular and coronary conditions as number 1 and cardiomyopathy as number 4 for the women here in Texas. Obstetric hemorrhage was number 2. So again, as we're thinking about the data that I'm presenting, I want you to be translating this to solutions. When you see obstetric hemorrhage as one of the leading causes of pregnancy-related death in Texas, what do you think? You think, oh my gosh, we're doing the solution. We are gonna change this problem. This is not what we're going to see because we are implementing Texas AIM. Infection and sepsis. Yesterday you heard several presentations that talked about the identification of early warning signs for sepsis and how to use those. This is another important cause of maternal mortality, and it's, again, something that we need to think about those solutions. Preeclampsia and eclampsia, the hypertensive disorders of pregnancy, maternal mental health conditions. We're gonna talk a little bit more as we go through this today, and then amniotic fluid embolism as a cause as well. So these are your big causes. I want you to remember these as the big causes of pregnancy-related mortality. We know that African American women disproportionately bear the burden of maternal mortality, and you can see here the overall Texas rate at 8.9 with African American women nearly double that. And this is such an unfortunate disparity. When you look at education, when you look at social status, when you try to adjust for all of these other factors, you can't educate this difference away. The income doesn't change it, where you live doesn't change it, this difference persists. And it's a call to us, a call to action to make sure that we can achieve an entirely different picture with all of our interventions. And again, we'll talk about some more of those in a minute, but I want you thinking about that now. These deaths are preventable. When we looked at the pregnancy-related deaths, these deaths are preventable. In fact, nearly 80% of pregnancy-related deaths were judged to have at least some opportunity for prevention. Cardiovascular disease, you can see in the blue, it represents what we believed as the committee as the potential for prevention. So cardiovascular disease, largely preventable. Obstetric hemorrhage, preventable. Infection, preventable. Hypertensive deaths, preventable. All of these are opportunities for us in what we do every day to do just what we saw in Illinois, right? Dr. Borders showed how they were able to change throughout their state the severe complications from hypertension simply by treating women rapidly. You make the diagnosis, you rapidly initiate treatment, and you change the outcome. And we can do just that here. As the task force is looking at contributing factors, we believe that it's incredibly important to acknowledge that this is much broader than medical care. This is broader than factors that we see at the individual and family level. It's broader than our healthcare system. We have to be aware of factors that are contributing from the community at large. We need to be able to look at those social determinants that ultimately create differences in outcomes. So the task force takes a very broad frame. It's still something that we're getting better at. It's something that we're working on across the United States. I've had a chance to work with some of the key players in the CDC Foundation's work on maternal mortality, and there's a lot of emphasis going into how do we appropriately evaluate these community factors that influence maternal mortality or contribute to maternal mortality. One of the other things that's really important to understand when we talk about contributing factors is there isn't one single factor that contributes to these deaths. In fact, in the task force review, we found more than 5 factors, an average of 5.2 factors contributing in each case. Understanding these contributing factors through those detailed case reviews is what truly gives us the opportunity to have a much better understanding so we know the changes that we need to put into practice. So one of the things that we noticed were that underlying medical conditions were contributing to maternal death. And I think it's really important for us to talk about why we're identifying these factors. Are we saying, when we say chronic hypertension or type 2 diabetes or obesity contributed to the loss of life for a mother, I think it's very important to understand that we're identifying those factors because those factors help us know which women are at higher risk and help us to identify the best interventions to put into place. We're not blaming moms. What we're doing is taking the opportunity to identify different solutions that we can put into place that will save women's lives. There were delays in or failure to seek care or treatment. Patients didn't recognize early warning signs, and we'll come back around in this journey. I'm giving you the stories of the women now, and then we're going to talk about different solutions that we're going to put in place to help us address some of these problems, to help us better educate women to understand these early warning signs. Provider factors played an important role in a number of these maternal deaths, where we as providers fail to recognize a woman's high-risk health status, fail to refer a woman who was high risk to appropriate specialists for evaluation and assistance in management, a failure to recognize and respond to those early warning signs that were presented to you so clearly yesterday. Delays in our diagnosis, delays in initiation of treatment, and in some cases, ineffective treatment that was used. Also, Dr. Borders, you heard so many of our team members who were speaking yesterday talk about the incredible importance of effective communication. Clearly, we need to do our best work every day. We can learn this effective communication in so many different ways. It played an important role in a number of maternal deaths. What about at the facility level? There were problems that the task force identified at the level of facilities as well. Once again, you'll hear these same stories of failure to recognize that a woman was at risk. Delayed responses to those clinical warning signs. Lack of continuity of care was also an important factor at the facility level. It's those handoffs, right? It's that, again, communication. How are you handing off this patient to the intensive care unit team? How are you handing off this patient to her postpartum care? How many times when I was working in large hospitals did I write a note that said, postpartum visit, outline clinic, 6 weeks? And that was the handoff. I can't believe that I used to do that. Thank goodness things are different now, but we all have opportunities to make changes just like that. It's incredibly important, those handoffs, that continuity of care, very, very important. And that lack of care coordination and continuity translates into our communities as well. There was poor coordination, as I mentioned, between the inpatient and the outpatient settings, but that interconception care, that care for a woman when she's not pregnant, is incredibly important. And in many of these cases, we saw women have no access to the health care they needed to be able to have their needs addressed. So I'm going to transition. We've talked about the data that we obtained from those very detailed case reviews, from the medical records, from the autopsy reports, from investigative reports that we received, lots of detailed information that provided us with that specific detail. The other piece of data, the other pieces of data that we have are very, very important as well. This is data, what I'm going to show you in the next several slides, is data that is taken from our vital statistics. And you're going to say, Lisa, wait a minute, like your fourth slide was that this is over-reported. Well, what I want you to know is that this data comes from a data linkage. So we know, in fact, that these women, the 382 women from 2012 to 2015 actually died either during pregnancy or within a year of the end of their pregnancy because they were matched to fetal birth or death certificates. So we have, these women are real women who unfortunately lost their lives. So for this time period, there were a total of 382 women that were identified. And you can see here that we have 215 women, a total of 215 women that lost their lives more than 60 days postpartum. The other large categories, while pregnant within the first 7 days postpartum, as you can see, these women largely were women who lost their lives either during their initial delivery hospitalization or shortly thereafter, and then going out to 42 days after the end of a pregnancy, which is the traditional international definition for maternal mortality. So what was number one? If we look at that entire year, what was number one? It was drug overdose. 64 women lost their lives due to drug overdose. The second most common was a cardiac event. Again, I mentioned that this is the same thing that we are seeing nationwide. Other states are reporting the very same information. Cardiac events are clearly very important. In many cases, unrecognized situations. As Dr. Ramsey reported yesterday, looking at the data that came from California, we're seeing those very same things that they saw in California, here in Texas. If we continue to move forward, other important deaths, deaths from hypertension and eclampsia tended to occur within those first 42 days. Those pregnancy-related deaths, also very important contributor to mortality and highly preventable. We saw that all of those deaths that we had due to hypertensive disorders that had the detailed case reviews, all of those deaths were believed to have been preventable. This was data that was very distressing to all of us. Homicide and suicide were also very important contributors to maternal mortality. And you can see that the majority of these deaths are occurring more than 61 days after the end of a pregnancy. We'll be talking, I'll be talking a little bit more about the importance of perinatal depression and how we need to be doing things to address perinatal depression. Homicide also an important cause, and the opportunities that we have. Again, think about opportunities for screening and potential interventions that can help prevent these deaths. I talked about the risk factors that we saw that were associated with maternal mortality. And what we're presenting here is the maternal mortality rate associated with each of these health risk factors in that population of women that we had, again, from our matching. And you can see the association with obesity, with diabetes and high blood pressure. Look at the significant association with smoking during pregnancy. Clearly, smoking during pregnancy, again, think about opportunities for screening, opportunities for intervention for this group of women. Late entry into prenatal care was associated with a higher maternal mortality rate. Whether it's limited access to prenatal care, opportunities for us to help women understand the importance of early prenatal care, these things all have an important influence on helping us address this particular risk factor. Cesarean delivery is also associated with a higher maternal mortality rate. And my partner, Steve Clark, has published on this concept that in many cases, it's not, in fact, the cesarean delivery that causes a woman's death, but in fact, many of these very serious conditions are associated with the need for delivery by cesarean. And therefore, we begin to see that association. And certainly that's not to say that cesarean delivery does not itself contribute to maternal mortality, but much of this is an association that we're seeing because of these serious conditions like morbidly adherent placenta, or those placenta accreta percreta situations, placenta previa situations, massive hemorrhage. The situation, the patient I had who had the intracranial hemorrhage ended up having a cesarean delivery. Again, in many cases, that associated with the disease that causes, associated with the cause of death rather than the route of delivery itself. So let's think about it. What's happening in Texas? What have we seen since 2007 with some of these major risk factors? Pre-pregnancy obesity is rising. And unfortunately, we see a disparity in pre-pregnancy obesity. We have an opportunity to work with women, to talk with women. George McCones was talking to us about how do we talk to our patients about having a healthy weight. He mentioned that those conversations can be difficult, but those are conversations that we need to have. You saw the associations. Here we see the disparity. These are conversations and opportunities that we need to take. Hypertension, diabetes also rising here in our state. Again, we're seeing the disparities. Latina women more likely to have diabetes, and African American women more likely to have hypertension. These again are opportunities that we need to take to ensure that we are providing the best care for women so that they can be at their healthiest. If we look at pregnancy is just this tiny sliver of a woman's life, right? It's a tiny 9-month sliver of their entire life course. And we need to be thinking about a woman's life over a much broader perspective so that we can ensure those better outcomes during that tiny slice of pregnancy. Reviewing all of this information, reviewing what we learned from our detailed case reviews, and then from all of our statistical analyses from the matched vital statistics data, what did we learn and what recommendations did the task force choose to make to reduce maternal mortality? The first recommendation, these are not in any particular order, but I will go through these recommendations with you. Increase access to health services during the year after pregnancy and throughout the interconception period. This gives us opportunities to improve that continuity of care that we talked about, to ensure those care transitions, and then to promote safe birth spacing. You've heard about initiatives for all of these different things yesterday. This is one of our key recommendations. And for those of you who remember the 2016 report, you'll remember that this was a recommendation in our 2016 report as well. We saw the important role that those high-risk maternal conditions play in contributing to maternal mortality. We need to be able to enhance our screening and referral for those high-risk conditions. We learned yesterday about a number of different programs for screening to identify these women, right? We talked about screening for substance use disorder and how we can best do that screening, how we can best refer these women in for treatment. What about screening for hypertension? What about screening for intimate partner violence? What about screening for perinatal depression? We learned about how to do all of those things. We learned about programs whose implementation can significantly improve outcomes. That is one of our recommendations. Care coordination and management. We talked about all of those opportunities where care was not coordinated between, even in some cases, a variety of specialists who were trying to manage a woman's complicated pregnancies. This is another incredibly important opportunity to enhance that communication, coordination, and continuity of care for women to reduce maternal mortality. A culture of safety. We can do this, right? We're already doing this. This is one of those recommendations that many of you have put into place already, right? I have to do this. How many of you, if we could just do a show of hands, how many of you are at a hospital who is implementing Texas AIM? Isn't that great? Just look around the room. I mean, it's amazing, right? All of you are doing so much already to address these. You didn't need to wait for this particular report. Implementing Texas AIM is an incredible opportunity for us to make a change in the culture of that hospital, just as Dr. Borders was talking about. Identifying other programs, identifying and implementing other programs to reduce maternal mortality from cardiovascular and coronary conditions, cardiomyopathy, and infection and sepsis. You saw those, remember, on the first, one of the first slides about pregnancy-related deaths, right? Those were incredibly important causes of pregnancy-related mortality. And so we are looking for interventions for these particular conditions. And I'll come around to talk about some of my ACOG presidential initiatives and let you know where we stand there. Improving postpartum care management and discharge education. We have so many incredible nursing teams here today. I know that many of you have already started doing initiatives that enhance the education that we're providing to our patients. And as providers, I learned a lot of my discharge education from my nurses. And I am so very grateful for all of the teaching that we had from our incredible hospital teams. But this also is very, very important. We saw that women were unaware of some of those warning signs, right? So this is a recommendation. Help raise that awareness so that we can ensure that women and families understand the risk factors that they need to be looking for. Clearly, we know that we need to do a better job to achieve equity in outcomes for African American women. I'll talk a little bit more about some of the exciting programs that we're doing to help specifically address this. Public awareness campaigns to promote health-enhancing behaviors. Also, incredibly important opportunity, right? We saw the impact of these chronic medical conditions on maternal mortality. And if we can have education campaigns that help women and families understand and help providers implement programs that help women achieve healthier behaviors. Championing integrated care models. I spent a large part of my career working in a facility where we didn't have a psychiatrist. In order to have a psychiatrist come and see one of my patients at a large county facility, I had to call, I had to beg, and eventually we were able to get the mental health services that we needed for our patients. That isn't a situation where we want to be. I feel fortunate now that I've been able to work in a practice where we fully integrate our behavioral and our physical health, where the records of our midwives and our physicians are readily available to our clinical therapists, our psychologists, and our psychiatrists. And the care team sits down together to talk about optimizing the health, the mental and physical health of a woman. That's incredible. It still makes me excited even today, thinking back to those days when I just didn't have those opportunities. And I want every single one of you to have that same opportunity, to be able to work in a truly integrated system where we can meet all of a woman's health needs working together. And finally, we needed some strategies to help support and improve the maternal mortality review process. There are a number of situations where we have difficulty getting medical records. We know that it's not an easy thing that we are doing to ask facilities, to ask provider offices to provide us with that information. But I think you've seen the incredible detail that we can derive from the review of those specific medical records. It's really valuable. And it really helps if we can get that information soon after it's requested. There were some situations where it took more than a year for us to get the medical records that we were trying to review. And we're really hopeful that we can sort of streamline some of that submission, but we're also looking at ways for us as a task force to be more efficient in our review of the cases, to move ourselves from 2012 to the present so that we can be providing you with that more up-to-date data that allows us to implement solutions much more quickly. So the task force itself is doing a lot of internal review. We've been working with team members from the CDC Foundation's Review to Action for assistance in helping us be sure that we're doing our very best work to provide you with the information that you need as you think about solutions. So let's talk about some of the solutions. We've talked about the women, we've talked about some of our data. You know what the task force recommended based on that data, but I hope that you've also been thinking about what you can do when you go home from here. Healthy Texas Mothers and Babies is our structure, is the Department of State Health Services structure that gives us a number of absolutely incredible programs. I'm going to talk a little bit just about the Perinatal Quality Improvement Network, and that is where, as you can see, the Maternal Mortality and Morbidity Task Force lies. It's also where the collaborative lies. The Texas Collaborative for Healthy Mothers and Babies falls under this same area within the Department of State Health Services. This is a great opportunity, again, for us to work together. As Dr. Lakey was making the presentation to Dr. Ortigue, it reminded us of so many years ago, the opportunities that we had to take a look at the maternal and child health landscape here in Texas and begin to put the pieces together to really make change happen. And that has happened. Everybody is working together in an incredible way to really contribute their own parts to identify the solutions and then put these solutions into practice. So some of the key initiatives that we'll talk about are risk-appropriate maternal care and then the maternal safety initiatives. I'm really excited that the task force has created a subcommittee to specifically look at key drivers and root causes of the racial disparities to get to that why. Why is this happening? Why are these differences persisting? And help us, again, develop specific solutions that we can implement. Are there cause-specific diseases? Are there differences in our opportunities for prevention? Are there differences in access to care and access to care of the highest quality? Dr. Borders presented some really important data yesterday talking about the access to the highest quality of care and disparities in that access in Illinois yesterday. I'm afraid that when we see our data, we may see that very same thing, that we don't have equitable access to the highest quality of care for all of our Texas women. And that's a place they achieved it. They were able to achieve it specifically with their hypertension work, but I believe in this group of people that we have here today, and I believe that we can achieve that in all of our initiatives so that all women have equitable access to the very highest quality of care. We know that we have opportunities. Again, we talked about patient-provider communication in the broader sense, and we specifically have opportunities with the health disparities, helping providers understand how to best communicate with all of our patients. When we were talking about contraception yesterday, we were talking about how different women may perceive contraception in different ways and how we need to be sensitive in our communications to different populations of women. I think that's a concept that applies much more broadly, and we have opportunities to better understand and to better communicate with all of our patients. You saw this slide yesterday, I know, from Jean Mahoney, who is an absolutely amazing leader of the AIM program nationwide. This really has been Jean's baby for a while, and it has been truly a pleasure to see the expansion of this program. This was one of my expansion of the AIM program throughout the country was one of my ACOG presidential initiatives, and I am so happy to see all of the green across the United States with states who have implemented the program, and especially excited to see Texas green having implemented Texas AIM. It's just an incredible opportunity, and as we look nationwide at the data, we are seeing improvements in hospital systems, even when we're seeing improvements, reductions in severe maternal morbidity in areas that are outside the bundles that are being implemented. So when you change that culture, when you change the way things work in our labor and delivery units, in our emergency rooms, when we change how things happen, when we change the culture, we change the outcomes. And so this is incredibly exciting to see the proliferation of the program. So the AIM safety bundles really are there to reduce severe maternal mortality using these best practices. As you know, we are working on obstetric hemorrhage as the initial AIM bundle, but you saw the important contributions of hypertensive diseases to maternal mortality. So that is a future bundle for us to implement. And finally, obstetric care for women with opioid use disorder. You saw the leading cause of death when we looked at our combined statistical data from 2012 to 2015, that opioids were a leading cause. And I am confident that as we look at the next sets of years of data, we're going to see those deaths from opioid use disorder continuing to rise. So I know this is an incredibly important area for us to work. There are a number of hospitals who are contributing to this work. There are a number of people probably in this room who've been involved in the development of these AIM bundles. If you've been involved in the development of the opioid information for the state of Texas, could you just raise your hand so that we can all be appreciative of who you are as contributors? Okay, we've got just a couple contributors here. Thank you so much. Thank you very much for your contributions to help us get this. The opioid bundle is especially important, I think, because it really spans the work that we're doing in the hospital with the work that needs to be done outside the hospital. So we're expanding from the acute care setting into the outpatient setting, and I think that's an incredible opportunity for us. This says so much. Now, I don't mean to brag on Texas or anything, and I had to wait till Dr. Main went home, but we have done an amazing job. You have done an amazing job, right? When we think, did you say this yesterday? How long? Okay, so it took California about 4 years to get to the same, about a similar level of hospital involvement that you have already achieved. 207 hospitals, 207 enrolled hospitals as of January 23rd. And you can see that this, I know, isn't that awesome? That is so incredible. And you look at this map, it's everywhere, right? AIM is everywhere. Hospitals all across our state, big hospitals, small hospitals, are all signed up to make an incredible difference in the lives of women and our families. So thank you all. I know it's hard work. That implementation side, this is hard. We know it's hard work, but it's the very work that makes the difference that we want to see. The Department of State Health Services has requested an exceptional item to help address maternal mortality. Somebody asked me yesterday, is this work going to cost anything? Well, there is a cost to it, but boy, this is an amazing investment in our future. This is an incredible investment in the future health of not only the women we touch, but in those families as well. This is incredibly important. So the exceptional item request included additional funding for implementation of maternal safety initiatives across the state. We've talked about the implementation of Texas AIM, implementation of a care coordination pilot. What did we identify as some of those contributing factors? Lack of coordinated care, right? So here you see a solution. We have a solution that's being proposed. Risk assessment. How many times did you see that as a contributing factor? Lack of identification of risk. Well, here we have an opportunity to develop and then train a wide variety of providers on how to identify risks and then be able to get a woman into risk-appropriate care. And we talked about the need for education, right? One of the recommendations of the task force was increased education for healthy behaviors. And here we have increased public awareness and prevention activities to ensure the best health for women and families. So what are the next steps for Texas AIM? What are the next steps beyond the implementation of the hemorrhage bundle? The opioid safety bundle is now being piloted. It's being piloted, as we heard yesterday, with programs who are participants in the Texas AIM Plus program. ultimately implementation of the hypertension bundle as well. Now, does that stop you from ensuring that women are rapidly identified with hypertension and rapidly treated at your facility? No, it doesn't stop you from doing that when you go home. But the widespread dissemination with the support that comes along with being in the AIM initiative, absolutely. And then as we look to the future, what's next, right? We've looked at our data. We've identified the interventions that we need to put in place based on the data from our Texas women, and we know what solutions we need. This is a continuous process, just like any other quality improvement process, right? We'll evaluate our data, determine the interventions that we need to make, and then put those interventions into place and sustain the changes that we see. And then again, as we do these different implementations where the staff is focusing their energy, we'll shift to identifying what's next. Is it sepsis? Is it a cardiovascular disease initiative? So moving beyond AIM, clearly there are some other things. We talked about how important it is, not just the care in the acute area, in the acute setting, right? Not just that hospital-based care. We saw the important contribution of maternal mortality during pregnancy and within the first 7 days, but we also recognize the important contribution outside that initial time period. These were really the incredibly important factors that increased the risk for mothers that we identified. So we'll need programming that helps us address these risks. The care coordination pilot that I mentioned when I was talking about that exceptional item really helps us pay increased attention to the health needs of women who are at risk, especially African American women. We need enhanced screening and referral. We talked about that in several different situations. Now you can think of a number of different areas where we have opportunities to screen and refer for treatment, right? We talked about postpartum depression, screening and referral for treatment. We talked about screening for intimate partner violence. We talked about identification of basic risk factors. We've seen situations where women didn't talk about some of the more complex areas of their medical history, I think in part because they may have been afraid about talking about some of these things. But great opportunities for us to identify both outpatient and inpatient factors that place women at risk. The care coordination program so that we can provide additional resources and link women to existing resources within the community. Think about the opportunities that you would have to implement programs with care navigators, for example, or better care coordination programs. So how do you take women in an incredibly complex health system and help link them to resources that are already available in their communities? How do we let the providers know what resources are available within the communities? These are great opportunities that we have to truly make a difference. And then educating our patients. There are opportunities I've talked about that we have to educate our patients about best care. So I want to talk to you just briefly from a national perspective. Back in 2011, with some amazing partners here in Texas, we first approached our Texas legislature with a desire to have Texas establish a maternal mortality and morbidity task force. We didn't get it in 2011, came back, worked with the Department of State Health Services in that interim time period, came back in 2013, and actually we were successful in establishing our state-based maternal mortality review. And I will tell you, when I was on the Hill advocating for this on a national level, it meant so much to be able to talk about our Texas experience and what an incredible job that Texas has done. We established the review. We've been reviewing cases. We made recommendations. The reports were read. Solutions were implemented, whether they were legislative solutions or solutions that were put into place in our hospitals, by our providers, in our communities. We had the data, We talked about the data, and solutions were implemented that save women's lives, and that's what this is all about. So when I was able to talk about that on a national level, it was truly impactful, and I was so excited to see the passage of this national legislation just before the end of the year. Truly, it was right at the last minute. If it did not pass at the end of 18, we were gonna have to start all over again from the very beginning. So it was a blessing to see this pass. The legislation provides funding and support for state-based maternal mortality reviews, and we're looking at how we can potentially be a recipient of some of the support that is available now through this program. So incredibly, incredibly exciting. Lots of energy around this. It's a great opportunity. Dr. McCone's. This slide was Dr. McCone's lecture yesterday, the whole lecture, talking about how we're really rethinking postpartum care, how it isn't the follow-up in outpatient clinic in 6 weeks, but instead, this is a journey. This is our opportunity to interact with the women on the frequency that they need as dictated by their specific situation so that we can ensure their optimal health. This isn't just that one-time visit. This is our opportunity to address all of a woman's health needs. And Dr. McCombs did a wonderful job yesterday talking about all of the opportunities that we have. And if you think about those recommendations, right, the things that Dr. McCombs was talking about, if we do those things, we will be providing best care for women. So I want to call out Dr. Pat Ramsey. Again, Pat, a number of years ago, invited me to speak in San Antonio at their pregnancy and heart disease conference. And I was so impressed with the information that I was learning. Really looked at the national data, knew what our Texas data was showing, and clearly we needed some new guidance on the management of heart disease and pregnancy. In fact, if you look at ACOG's guidance on heart disease and pregnancy, it's about the same age as my son, who's a freshman in college. So yeah, we needed some new guidance. So I'm really excited to say, and thank you, Pat, for being a part of the task force. ACOG has put together new clinical guidance on pregnancy and heart disease, and not just the heart disease that we know about, right? We're not talking just about the woman who was born with congenital heart disease, who was able to survive and is now having a child. We're not talking about just those women. We're talking about the incredibly increasing numbers of women who develop heart disease contributed to by the rising rate of other complex medical conditions. So we're talking about new information to help us identify those women, help us get the right women the additional evaluation and treatment that they need to be more healthy. The other thing that's really important and will be a part of this clinical guidance is the recognition of certain obstetric complications as unmasking this later lifetime risk for cardiovascular disease. Did you know that preeclampsia, hypertensive disorders of pregnancy, gestational diabetes, diabetes of pregnancy, or having a growth-restricted baby all basically are associated with a doubling of heart disease risk later in life? So if we think about the fact that this probably includes at least 1 in 10 women in this room, that's important information to know. If you had one of those pregnancy complications, you do need to be treated and followed in a slightly different way than women who did not have those pregnancy complications. And so we'll be addressing that in this new clinical guidance as well. Other clinical guidance. ACOG is working on developing new guidance and interventions for maternal mental health to help us address perinatal depression and anxiety. These are incredibly common disorders. 15% up to 20% of some of our patient populations suffer from perinatal mood disorders. So ACOG has been working really hard to identify the best resources that we can disseminate to ensure that women have access to high-quality behavioral health care. We had a maternal mental health summit in mid-December at the national office, and one of the most important things, we called in providers from all sorts of different organizations and included our public health partners such as AMCHIP. One of the most important things that other providers, many in other specialties, did not realize was how incredibly common perinatal mood disorders are, and what an incredibly important contributor suicide is to maternal mortality. We saw that, remember, in our very early data, and that is an opportunity. That is something that we really need to address. So great news, we'll continue to have some additional information coming out of ACOG. Some of you may have participated in our regional meetings where we were piloting a collection of tools to help OB-GYN providers, women's health providers, physicians, midwives, for example, with identification, assessment, and that initial intervention. If you're an OB-GYN, can we get you comfortable to start that first course of antidepressant medication while you're getting your patient the other services that they need as well? So more to come, a lot more to come on this particular topic. This is one of my absolute favorite documents. And some of you may or may not have seen this. This is from A1. And when I first saw this program, I was incredibly excited about it. And it's so funny, I had the privilege of working with Summa Marketing a number of years ago, assessing postpartum materials. And Summa has done some focus group testing of this particular intervention, and they liked it. The women liked it, Texas women like it as much as many of us do. So that's incredibly exciting information for us. These are the post-birth warning signs. And again, this is available on A1's page, the post-birth page. What A1 did was they studied their nurses who are members of their organization, and they identified that more than half of discharge education at the time a woman leaves the hospital after birth, more than half the time women received less than 10 minutes of education, and in fact, many women got less than 5 minutes of education. And so the next thing that they did was they asked their members, what are the topics that you cover in that post-discharge education, right? Are they the most common causes of maternal mortality? So we saw, what was our number one cause of pregnancy-related maternal mortality here in Texas? Cardiovascular disease. So do you think cardiovascular disease was number one on this is the discharge instructions that we give our patients, signs and symptoms? No, it wasn't number one. In fact, it was at the very end. About 7% of A1 members reported that they were educating their patients about the warning signs of cardiovascular disease at the time of hospital discharge. So a great opportunity, and A1 owned this, they took it, they developed an incredible education program for you. There is a charge to this program, all of that goes to A1. I'm not associated with A1 in any way, I just think it's a really awesome program. So take a look at this. This is really simple information for our patients. I've actually found it's really great information. I took it with me when I did some other lectures just in the broader community, because if our broader community knows that these things, chest pain, obstructive breathing, shortness of breath, seizures, and thoughts of harming yourself or your baby, those are 911 phone calls. Everybody needs to know that, right? Everybody needs to know those things in order to make a difference. So I hope that what you have seen today is that journey from the stories of the women, developing an understanding from the data, making recommendations, and then having solutions that we can implement in our everyday work that really will save women's lives. So that's it. I thank you very much for your attention.
So thank you, Dr. Hollier. I understand we have a few minutes. We could take a few questions. So we have a couple of microphones here in the audience. If anyone has any questions for Dr. Hollier.
Hi, thank you so much for coming. I did have a question about who exactly is on these task forces, and I know like some people you've already thanked, so I know some of these forces already have members, but I was just curious to know like how you maintain balance, you know, information-wise or people's specialties and things of that nature.
Thank you so much. That's a great question. So the Maternal Mortality and Morbidity Task Force has its membership defined by legislation, and the members are appointed by the Commissioner of the Department of State Health Services. So if you'll go out to our Maternal Mortality and Morbidity website page, you can see who all of the members are, and then you can also see when there are opportunities to apply to become a member of the task force.
This microphone over here.
Hello. I have a comment and a recommendation. I'm an OB-GYN doc, and I work for a small health plan here in Austin. So when I hear all of this, I think about the payer community and how they are or aren't involved in all of this. As we talk about all of these solutions, they all make sense. I applaud what the recommendations are, but they all take time. And our current coding and payment system does not support that level of time commitment. And I don't think the time necessarily has to just be physician time. So I think we in the payer world need to work better with all of the provider community to come up with better and more creative funding and payment mechanisms to support these recommendations. Lisa's at an institution where they've been able to put the payer functions and care functions together.
Yeah.
But most of us don't operate in an environment like that yet. So how do we involve the payer community to better support all of these recommendations? We can at least first work with Medicaid, and that covers 50% of the births in Texas, and I assume the rest of the country. And then maybe if we can come up with some creative things within Medicaid, we can use that to leverage with the private payers.
I agree. I think there are a lot of opportunities with the payer communities, both Medicaid and with private insurance. I had the opportunity to give a similar presentation to the HHSC Quality Forum, where all of the medical directors for the Medicaid managed care programs were in attendance, and we had a really robust discussion about the opportunities that MCOs have to be a stimulus for improving health outcomes. I think, just briefly, I will say, I think the payment reforms are incredibly important and opportunities to shift the way we pay to incentivize people for optimal outcomes, to look at different payment models where there are payments on a broader level that allow you to have other types of care providers who work with you as well, maybe care providers who are not traditionally paid through a fee-for-service mechanism. So I think looking at alternatives to fee-for-service, both in the private world and the public world, but I think also opportunities for us to look at how we make payments to hospitals and how we incentivize behaviors at the hospital level as well. Resources are necessary, and maybe there are different incentive payments or different ways payments can be structured that incentivize hospitals to be able to have the time and resources that we need.
Hi, excellent presentation. Thank you very much for it. I've also and am involved with Medicaid managed care, and I was in Texas originally, and now I'm in Maryland, and a lot of the issues are the same. The 800-pound elephant in the room in terms of coordination of care and payment reform is coverage for these women after pregnancy. And so I think that while the MCOs and all the stakeholders work on all the issues that you outlined, the coordination, the payment models, we need to advocate with the legislature to extend coverage. And this is very important for a condition that's very close to my heart, and that's gestational diabetes. And so I was involved with a grant in Maryland where we looked at the care that women got after they were diagnosed for gestational diabetes during pregnancy, their aftercare, and it's non-existent because they lose coverage. They don't get the handoff to a PCP at all, whether they have diabetes or anything else, any other chronic condition. The follow-up care with a PCP or specialist is almost non-existent. And so, I think, that we need to look at that. Also, specifically for gestational diabetes, I think, as with perinatal depression, I think pediatricians can play a big role in that. I know that in some practices, pediatricians are screening moms for gestational, for depression, and I think that's very helpful because the moms will bring their babies in for follow-up care when they won't take themselves in. And I think by the same token, all babies that are infants of diabetic moms have that diagnosis. So that's a great opportunity for pediatricians to talk to moms with babies with that diagnosis about follow-up for their gestational diabetes.
Absolutely. Thank you so much.
I think time for one more question.
Yeah, great data, thank you. I was looking at the data, birth and outcomes and stuff. We're looking at data for terminations and outcomes, because some of that is teens terminations early to late, and some of these recommendations would be great to be pushed over to pediatricians, who teens usually once they deliver don't follow up with their OB-GYNs, they follow up with their pediatricians. So I was wondering how should we be thinking about recommendations towards the pediatricians that you've been presenting, and are we looking at any type of data from terminations to outcomes?
I'm going to address the collaboration among all of the different professionals within the medical field. It is incredibly important, and we have worked really hard to ensure that all of the different types of healthcare providers are working to address this. I want to send out, thank you for the opportunity to give a big shout out to the Texas Medical Association for working with us on the maternal mortality issue. They have just done a really wonderful job. Their immediate past president having championed this issue and really, I think, contributing very meaningfully. So all of us in medicine, this isn't about OB-GYNs, and we won't be successful. We will not be successful if only OB-GYNs are doing this work. So we need to ensure that all providers in the family of medicine are doing this incredible work. And just very briefly, I know we had time's up like 2 questions ago. So just very briefly, I know that from an ACOG standpoint, advocating for access to interconception care is going to be incredibly important. ACOG will be advocating for an extension of Medicaid benefits for a year postpartum, both on a state level. The final ACOG advocacy priorities will be determined in the first week of February at our board meeting, but I imagine that our national ACOG organization will also be advocating for an extension of Medicaid benefits for a year following the end of a pregnancy for all women. So excited about those opportunities.
All right, if you can please join me in thanking Dr. Hollier.